Be all right.
Sure, that sounds great.
Well, I'm glad I see people are ramping up as usual the numbers, and glad people are here because you're in for a treat. Dan Cahill is our guest this month, who is going to give grand rounds on precision medicine for brain tumors. And this is really a field that Dan, Dave Lewis, a number of other individuals, key individuals around the country, have developed, and other institutions have embraced as they should. The World Health Organization grading system is now, I don't know if you'd say defunct, but just really completely revamped based on this work. And I find it very exciting. Dan is currently an associate professor, but may not be for long. And at MGH in the Harvard system, he trained at Harvard after going to Johns Hopkins for his MD, PhD. He did his undergraduate work at Yale, which is very smart of him, and then did his residency at MGH. After MGH, he went down to the University of Texas at MD Anderson Cancer Center for 2.5, 3 years, I guess, then was recruited back to MGH, where he's been since that time. So it's really a pleasure, Dan, to have you. We very much look forward to this presentation, and thank you very much for doing it. But please, Brigitte, please go ahead.
Thanks so much for having me. And I just want to start off by saying, or taking the opportunity. You always, you have to thank the people who trained you and made you who you are. And you know, everything that I've been able to really accomplish in neurosurgery, to large measure, is due to Chris Ogilvie. He's taught me so much about what I know and how to really be a neurosurgeon. And so I want to take the opportunity to thank Chris for the opportunity to present. And so today I just want to talk about basically precision medicine, so genetics, mutations, and how in the last 10 years or so we've started to understand how they impact our understanding of brain tumors, both from a classification standpoint and then also from a treatment standpoint. And I just want to try to highlight some areas that are going to need a lot of work in the next few years, and then areas where we've had some pretty good success in terms of transforming how we take care of patients and how we can make things better for patients. So as I talk about, here, let me see, there we go. As we talk about genomics, or mutations and how they cause brain tumors, this is really a multi PI effort. There's lots of folks both at Mass General and throughout the Harvard system and throughout the world who we work together with in collaboration to try to sequence and understand how these tumors are formed. Excuse me. So first of all, and this is a statement that I think everybody would agree with, is that when we think about just the general management of cancer, so oncology, medical oncology in general, over the last 20 years, this has really been revolutionized by the discovery of point mutations and then drugs that are matched to those point mutations in order to manage tumors. So when we think about melanoma, there's the BRAF mutations, which are managed with, now dabrafenib, trametinib, or oncobini. HER2 in breast cancer, that amplification being targeted by Herceptin. The PI3 kinase mutations being targeted in breast cancer in using Gleevec for patients who had GIST tumors or CML, and then obviously EGFR for erlotinib or osimertinib in lung cancer. And these have been transformative in terms of how we manage patients. We try to find the mutations in patients when we first see them. So if a lung cancer patient comes in, it's really starting to, and has become the standard of care to try to figure out if they're EGFR mutant or not, and then try to bring them along a treatment pathway that corresponds to that mutation status. And so, to a large degree, early on, as this sort of precision medicine ideas were transforming medical oncology, there was this idea, we should try to use that in gliomas, or specifically in malignant gliomas. But that was relatively unsuccessful for many years. And I think the reason targeted therapies have been ineffective in malignant gliomas is mostly due to the heterogeneous pattern of growth of these tumors. So glioblastoma multiforme, it has many different sub branches of evolution. And this was from a paper we published in 2011, where you could see that there were cancer cells throughout the tumor, throughout this slide here, but some of them had EGFR amplification, some of them had MET amplification, some of them had PDGFR amplification. There were lots of different subtumors within the overall tumor. And so then even if we were successfully treating one subtumor, like we killed all the green cells here, there was still more than enough cells to repopulate the entire tumor and just not be susceptible to your treatment. And this kind of heterogeneity is really a reflection of rapid evolution that's ongoing in growth of these malignant tumors, glioblastoma. We looked at this in a paper that we wrote just in the last few years, looking at the phylogenetic origin of glioblastoma. And what we did is we compared patients who had upfront surgery. We had the tissue from them from their first operation, and then we had the tissue from them at autopsy, so the ultimate clone that killed the patient. And we have a brain donation program at MGH where we had lots of patients. We were able to identify paired samples of initial surgery and surgery from the, analysis from the autopsy specimen. And then what we found when we looked at the genetic events was that we did find lots of amplification events, EGFR, MET amplification, HER2 amplification, but these were very heterogeneous. So sometimes they would be present in the initial tumor and absent in the recurrent tumor. Sometimes vice versa, they wouldn't be present in the initial tumor, but they would develop over the course of the patient's disease, even just over a few months of treatment. And so there was this shifting sands as you were trying to treat these patients, and how could you target the mutations. And so just as an example, here's a patient who had an EGFR mutation. The initial, this is what we call the most common recent ancestor. So this is a phylogenetic, a calculated precursor lesion. This is actually the pre-treatment sample, which is a branch off of that precursor lesion. And then what you find is, even though you can get rid of this pre-treatment sample by resecting it, essentially that's what you're doing to cure this branch, you're not able to chase the roots all the way back down the phylogenetic tree. And then it rapidly evolves another branch off of that root, and then gives rise to a subsequent progression event that is resistant to treatment with EGFR inhibition. So even though the pre-treatment sample could be targeted with EGFR inhibitor, it doesn't get all the way to the roots. And it's the same thing when we see in a MET amplification. So this is another example. We have a pre-treatment sample. It has a MET amplification. We treat it with a MET inhibitor, but that doesn't mean anything. All it does is it prunes the tree back to this root here. And then the weed, the weed that is glioblastoma just generates a root that has no MET amplification, and then it's resistant to the treatment. And so what we found is there were really only 4 core trunk alterations that would never get trimmed back all the way during treatment. And these were things that were whole chromosome alterations, so deletion of chromosome 10, amplification of chromosome 7, a focal deletion on chromosome 9, which corresponded to the famous CDKN2A or P16 deletion, and then point mutations in the telomerase TERT promoter, the telomerase reverse transcriptase promoter. The problem with these 4 alterations is that none of them are coding alterations. So all of our targeted therapies work against proteins, and that means that glioblastoma really at its core genesis may not be amenable to treatment with standard targeted therapies. And this also extends to things like immunotherapy. Anything that really targets protein-based changes may not work in a tumor where the core alterations that define the tumor aren't actually protein-based. And that so the ability to evolve around any targeted therapy limits our ability to treat this tumor. So what is this distinction? And this is a really important, if we have one lesson from the whole talk that I'm going to give this morning, this is the key slide, is that when you think about precision medicine for brain tumors, there's a key distinction between malignant and heterogeneous or evolving tumors and more benign lesions, lesions that grow as focal lesions and really have simple genetics instead of this complicated stew of diversity. And so this has important implications for who we should pick for targeted therapy versus other treatments. So highly unstable malignant disease can really just evolve during the course of treatment, and this limits our clinical impact. On the other hand, targeted approaches probably will have maximal impact in tumors that have low mutation rates and are simple genetic tumors. Now, these can still be bad tumors clinically, and I'll show examples here where the reason we want to identify them is because these are patients who we can do a lot of good for by treating them with targeted therapy. And the classic examples are historical. So when we think about examples of this, we look to these like germline benign syndromes. So, the hamartomatous syndromes, things like tuberous sclerosis. These are tumors that are caused by mutations in TSC1, which is on chromosome 9 in the germline of the patient, or chromosome 16, TSC2 mutations. These patients get these, these so-called SEGAs, or subependymal giant cell tumors, which form in the ventricular lining. This is the classic example shown here in this New England Journal paper. And then because these tumors have mutations throughout the tumor in these TSC proteins, they're susceptible to treatment with mTOR inhibitors. So everolimus or Afinitor can be used and is actually very effective in shrinking these tumors and providing benefit for patients who have these syndromes. Now, of course, it really just raises another clinical management strategy, because the question becomes, so when you initially see a patient, you think, okay, I have to do surgery on this patient because they're having hydrocephalic obstruction. You can treat them with everolimus and get them through that crisis instead of having to take them to surgery. But ultimately, they're still probably going to need surgical management because the tumors don't get cured by the everolimus. So you still have to think about the positioning of when you're going to do surgery in these patients, or are they going to need CSF diversion, these kinds of questions. And so another classic example of a benign tumor that's being revolutionized with this treatment is meningiomas. And so this sort of classification of meningiomas, there's been a long history of this in neurosurgery, dating back to really Cushing at the earliest stages. I mean, Cushing is famous for his management of meningiomas. And there's all these different histologic subtypes, meningothelial, fibroblastic, that form into the different grades of WHO, so grade 1, grade 2, and grade 3. And what we're learning as the WHO is sort of making the transition to the molecular era is that many of these subtypes actually correspond to specific molecular subclasses of meningioma. And we'll just talk about that over the next few slides. But the take-home message is that some of them are going to be very targetable, that we can treat with drugs. Others are not clearly targetable. And what we're doing with the molecular genetics is just recognizing the bad tumor ahead of time, which has actually been a long sought after goal in meningioma. We take out these tumors. Most of the patients do very well. Some of them do terrible. And the question is, could we identify those people early so that we could intensify those therapies? And at least in some cases now, we can actually identify the patients who are going to do badly. Those grade 2 tumors that we should be worried about, and how do we take care of them? So the problem with the histologic classification was that histology didn't really give us a prediction for treatment response or prognostic value, especially with grade. Many of us have the experience where we operate on a patient, they have a grade 2 tumor, and you do a good surgery and the patient does great. And you're trying to understand, why is it that that patient did well, but on the other hand, we have a grade 1 tumor, perfectly wide resection, and then the patient's regrown within a couple of years. The response rate to chemotherapeutic treatments in grade 2 or 3 meningiomas is terrible. It's basically 0% or a single-digit percentage across many studies. And the molecular genetics of meningiomas outside of for decades was really focused around NF2 because of the NF2 germline syndrome, the neurofibromatosis syndromes. And so there's a long history of understanding meningiomas and subclasses that are NF2 mutated or associated with neurofibromatosis as a germline syndrome. And then there's the subgroup that's NF2 wild type that's separate from that. And more recently, there's been this explosion of understanding of the NF2 wild type subgroups and the different mutations that account for how those meningiomas develop. And we've contributed somewhat to this literature, but this has been driven by many different groups. Murat Ganel's group at Yale, the groups at Dana-Farber, the groups in Heidelberg in Germany. And so there's been a lot of study of this. So meningioma, generally speaking, is a relatively simple tumor at a genomic level. So most of the mutations in terms of copy number or point mutational events or even translocations is very low in meningioma compared to more complex tumors like glioblastoma or other systemic cancers like melanomas. And this is work from my colleague Priscilla Brastianos that was published in 2013. And these mutation rates being low means that this is the kind of tumor where we're trying to go search for targeted events so that we can then identify drugs to treat these patients. And notably, even back to these earliest sequencing events, we were able to, or the groups that studied this were able to find mutations in targetable um, protein coding changes. So one was in smoothened, which is a targeted event that occurs in a cell development pathway, AKT and mTOR, which are well-known events from systemic cancers. So mutations in AKT, it would be a point mutation, always the E17K mutation. This would happen in NF2 wild-type meningiomas. There was a preference for skull-base tumors, so patients who had these sort of anterior skull-base lesions along the foramen magnum or around the clinoidal region would have mutations in this gene. And there were mutations in mTOR or the PI3 kinase pathway, similarly in this sort of lateral sphenoid area. These can be difficult tumors to deal with surgically. It can be hard to completely resect these tumors. This mutation is a known transforming mutation in AKT. It drives growth of these tumor cells, and there are known inhibitors for this gene in clinical trials. Smoothened, on the other hand, these mutations were found in different point mutations in the smoothened gene. And again, these were NF2 wild-type meningiomas. What's interesting about the smoothened oncogene is that this is found in basal cell carcinomas, medulloblastomas. It's not really clear what links all of those tissues together to understand it as a pathway. On the other hand, in meningiomas, smoothened mutations almost exclusively happen in olfactory groove tumors. So smoothened, obviously olfactory groove tumors, often we can cure the patient just by taking them to surgery. It's a complex surgery, and especially for those larger tumors, it can be very morbid for the patient. And so we have to be careful in terms of taking the patient through the surgery. But this speaks to that timing question. So, as we look at patients who have these like larger olfactory groove tumors, we're thinking of a future where if we could give a patient the smoothened inhibitor, maybe in a neoadjuvant setting, so for a month or two before the surgery, that would shrink the tumor. Shrinking an olfactory groove tumor even by a centimeter or so might make the surgery dramatically safer in terms of being able to cure that patient. And so that's the kind of thing that we think about when we look at managing meningiomas in the future. And then lastly, there's the PI3 kinase mutations that were discovered by the group over at Brigham, looking at these lateral skull-based tumors, which can be sometimes difficult to manage, and offering PI3 kinase as a targetable alteration in those tumors. Lastly, there's these classifier alterations. So one of the things that's very interesting is that about 30% of tumors have mutations in what's called TRAF7 in meningiomas. Is this gene called TRAF7. There's a subgroup that has these KLF4 mutations, which are found in secretory meningiomas. Almost all secretory meningiomas require surgery just because of how much edema they generate. So you have to take the tumor out, even if it's very small, in order to provide symptomatic relief to the patient. On the other hand, the TRAF7 category in general, those patients have they almost never demonstrate progression to higher grade. And so this is one of these sort of protective alterations. Or so when we find it in patients and we know that they have a TRAF7 mutation, that's a patient who will almost never progress. They will never go to higher grade disease. And so this is a subgroup of cases where we could think in the future, oh, maybe this is a patient who doesn't need radiation postoperatively, or who doesn't need that kind of aggressive following of a patient after you resect a meningioma. And so what we're trying to do is to make this landscape for meningiomas where we can identify the patients who are going to do well and also identify the patients who are going to do poorly. And then that middle group will be smaller in terms of our follow-up, where we have to follow the patients closely because we don't know which way they're going to go. In terms of these poor actors, then we have a few more recent findings. So one is these rhabdoid features tumors. So patients who have rhabdoid histology in the WHO criteria are considered grade 3. And that's because historically they've had poor outcomes, even though they are NF2 wild type. So it turns out that in an effort led by Ganesh Shankar when he was a resident at MGH, these tumors have mutations in a very specific gene that's part of this BRCA complex, which is called BAP1. And so BAP1 alterations were found very commonly in about 50% of meningiomas that have rhabdoid features, and is really part of the diagnostic criteria for rhabdoid tumors now. This is work led by Sandro Santagata, who's a neuropathologist at Brigham, and showing the loss of this tumor suppressor gene, this gene, is a way to identify patients who are going to have bad outcome or are true grade 3 type tumors. And these are tumors who then we can prioritize for sort of early systemic treatment or aggressive treatment with radiation, things like that, early after the initial diagnostic surgery. This just talks about the BAP1 gene and its known involvement in this BARD complex, BRCA associated complex. It's interesting, BAP1 actually is also found to be mutated in tumors of mesothelioma, which when you think about what mesothelioma is, that's like the meningioma of the lung. So it's the tumor of the lining of the lung. And the genetics of mesothelioma actually has a lot in common with the emerging genetics of meningioma. And so there's an interesting biological parallel that runs through those thread of tumors. So it turns out, and this is what I just referred to, so patients who have BAP1 altered tumors do incredibly poorly compared to the normal expected natural history of meningioma. So if you identify a patient who has loss of BAP1, you can't really be counseling that patient to say, oh, we've taken the whole tumor out, we expect you to do very well, because that's what meningiomas normally do. This is a patient who really has a much more aggressive disease than that, and so you have to follow them more closely. You have to counsel them that they're going to likely need further treatment. What should that treatment be? That's really experimental. There are studies looking at immunotherapy for these types of patients, for EZH2 inhibitors, which are things that target that BARD complex. And those types of patients, these would be good candidates for those types of studies. The other alteration that we found, and this was initially identified by the Heidelberg group, and then in my with work done with my close collaborator in Dresden, Tarek Giratli, we found that the TERT promoter mutation, which is the mutation found in glioblastoma and many other systemic cancers, is also found in a very high percentage of these recurrent aggressive meningiomas. So up to about 30% of recurrent progressive meningiomas basically acquire this TERT promoter mutation that we typically find in glioblastoma, and it is a terrible prognostic marker. So you can argue, and some authors have argued, that this is the grade 4 meningioma. This is basically the glioblastoma of meningioma once you find this mutation. And so this is an example where this was a patient, she was in her 70s. This was a grade 1 tumor when it was taken out. And certainly the surgery was very good in this patient, but within a couple of years, there was a very marked regrowth here. And then looking at this tumor on recurrence, it had the TERT promoter mutation. And then also, and this is very ominous, as I said, meningiomas typically have very benign or simple genetics. They don't have that heterogeneity that we see in glioblastomas, but the TERT promoter mutant meningiomas, they start to develop this heterogeneity. And so when we sequence different subsets of the tumor, we found that the TERT promoter alteration is found in certain subgroups, but not in other subgroups. And this kind of spatial heterogeneity is one of these very worrisome things about the evolution of meningioma. Of course, TERT promoter mutations have a terrible, terrible prognosis. These are patients who will die within three years or so of the diagnosis of the TERT mutation. For a meningioma, that's really unheard of. So based on all this emerging landscape, we've worked with the National NCI Trial Consortium, the Alliance for Clinical Trials, looking to develop a platform to try to target appropriate meningioma subgroups towards appropriate targeted therapy, so we can start to figure out how to use these treatments for patients. Should we integrate them in the neoadjuvant setting before surgery? Should we integrate them early after you've resected the tumor, so an adjuvant setting? And so for the earliest studies, what we've done is we have smoothen mutation subgroup. And so this is a group of patients who primarily have olfactory groove tumors. They have the smoothen mutation, and there's a known smoothen inhibitor, vismodegib, which is used for patients who have medulloblastoma and can be used in these patients as well too. There's the AKT mutation, so for these difficult skull-based tumors, which are hard to completely resect or they overgrow the cranial nerves, these patients can receive an AKT inhibitor, and we can try to see if we can slow the growth of these tumors. There's certainly case reports from Michael Beller's group in Zurich, showing that AKT mutations can be targeted in these patients. On the other hand, NF2 mutations, this is a huge, huge population of patients who have progressive meningiomas. And there are ways to, NF2 works as a cytoskeletal protein. It works with cytoskeletal signaling. And so the FAK inhibitor has shown a significant promise in this subgroup of patients. And there's also a very canonical pathway where these patients will also get CDK alterations. And so there's an arm on the study now to try to look to see if NF2 mutant patients could be treated with CDK inhibitors as well. So the endpoints for these studies are either response rate or stability, 6-month progression-free survival. Response rate was selected as an endpoint because of the terrible historical response rate in meningiomas. Typically, they don't respond to chemotherapeutic treatment. So if we saw any targeted therapy that provided a response rate above that historical baseline of essentially 0, we would like to study that drug further in that subgroup of patients. And so we have added expansion cohorts to this platform trial as it continues to accrue patients nationally. So in summary, meningioma genomes are relatively simple. Sequencing has, genomic sequencing has uncovered a number of clinically significant alterations. And the alterations really are associated with different clinical phenotypes. So they either identify patients who are likely to have a very good prognosis, and then maybe we can de-escalate therapy in them, or they're in specific subgroups that are very, tricky from a clinical standpoint. So they're in the skull base, or they, even though they're grade 1, they're crowding the skull base or cranial nerves. And so you need to have, a patient is losing vision and you need to have a treatment for that patient. And so there may be some unique opportunities to treat those patients with targeted therapy to provide a rescue that is not surgical, or a neoadjuvant way for the smoothened mutations to treat a patient who's going to have a difficult olfactory groove surgery. And then they have these progressive alterations. So this is a way of us identifying patients who are going to do poorly, and then try to treat them more aggressively with immunotherapy clinical trials, or clinical trials of systemic chemotherapeutic agents for patients perhaps who have the TERT mutation. So anyway, so I want to just pause there and sort of talk about how, or just maybe take questions, or just take a pause here and think about, this is going to revolutionize how we think about meningiomas going forward. And the new WHO criteria are going to have to start to incorporate these subgroups. And we're going to have to get away from this idea that, there's just a gradation of good to bad, grade 1 to grade 3. It's more like there's different subclasses. Some subclasses are very favorable, but some subclasses are bad. And recognizing different types of bad tumors is going to be an important factor too as we go forward.
Hey, Dan, can you identify radiosensitivity with this? I
Yeah.
know immunotherapy is being worked on, but are some of these more radiosensitive than others?
I think that's the key question. So for me, the opening question, really the opening shot in this universe should be the TRAF7 mutant tumors who do well. So those patients seem to do very well. Do they do well because they're radiosensitive, or do they do well because of intrinsic biology? And I think that's a key question right there. Are these patients, are the TRAF7 patients who we should not be radiating, or are they patients who we should be prioritizing for radiation because that is what is giving them the good outcome? And a lot of people, the use of radiation, and this is I'm speaking to a neurosurgical audience, so this is no surprise, right? The use of radiation in these patients is highly controversial. There are some centers that feel very strongly grade 2 patients should never be radiated. You should watch them and then deal with the recurrence. There's other centers who feel grade 2 patients should be all radiated, and that's sort of the spectrum of opinion in that area is very wide. And what I would like to start to think about is a future where we try to use these mutational landscape alterations to pick, this is a patient who should not get radiation, this is a patient who should get radiation. And then how do we make those choices really is driven by the types of factors that you're talking about. Are these radiosensitive tumors? Are these radioresistant? Or is this just a tumor that's going to do well no matter what? And so then we can spare the patient the toxicity of radiation. So those are the questions that we have to look at in the future going forward.
Dr. Cahill, if I may ask a question. This is Eric Wong from Neuro-Oncology. So you earlier mentioned that glioblastoma, there are a lot of heterogeneous mutations. So we all understand that by the time a glioblastoma is diagnosed, it is pretty far along in the evolutionary process. So what do you think is the driver for this type of heterogeneity?
Right.
That's some insights.
Yes, that's a very good question. And so, you have to try to look and see which of those, I mean, at least the way I think about it, which may or may not be correct, is that of those 4 core alterations, the TERT promoter alteration, the gain and loss of chromosome 7, and then the loss of P16, it does really feel like those have qualities of driver alterations, but none of those, it's not immediately obvious how any of those things would be driving that heterogeneity that we see, that diversity, that constant evolution of change that seems to occur from this reservoir of the phylogenetic origin of the tumor. And I think, to me, one question would be, now that we kind of know these alterations, could we find patients, older patients who are likely to develop glioblastoma? Glioblastomas develop most commonly in older patients. And so is there this opportunity for like a survey? As we all know, like CML, for example, there's a large group of patients who have CML, and then only a small percentage of them develop blast crisis later. And, maybe there is this quality of CML, but of the brain. So patients who have TERT promoter mutations, and there's a long precursor lesion or precursor phase, and we just don't diagnose it because we're not screening patients for that. And that might be a way for us to try to understand how this diversity develops. How would we get access to that, patient population? It might be in the CSF profiling studies for dementia, something like that, where we have, large banks of biospecimens, and then we try to find precursor lesions of glioblastoma in the small subset of patients. Something like that might be a way that we can try to get at understanding that early biology of glioblastoma. It is certainly true that once we find the patient clinically, once they have glioblastoma, the cat's out of the bag. It's running at that point, and what can we do to treat it at that point? Is it really feasible to be screening large populations of 60 and 70-year-olds? Right now, I don't think so. Also because we don't really understand this precursor phase. But maybe that's really where we need to go, if we want to start to prevent the occurrence of that late stage. So, thinking about how we can get access to that early stage is kind of the future probably for glioblastoma.
Then is there an attempt to use radiomics to look at these mutations and meningiomas?
Yes, and I would say that is something that is that's a key thing, and it's very active. It's very clear that certain locations, as I alluded to, are more commonly mutant. Like the olfactory groove have the smoothen mutation, and the skull base have the PI3 kinase AKT mutations. And so there's the location aspect of radiomics, and then also there's that quality of heterogeneity. And I do feel for the TERT promoter alterations in particular, we may be able to make a radiomics-based criteria because to capture that heterogeneity. Typically when we see a meningioma, the classic appearance is a very homogeneous enhancement, and it might be that heterogeneity of radiation or radiographic appearance might correspond to the presence of these mutations. So I think that is a very active area as well too, because that would be the kind of thing that you would, one of the problems with clinical management of these things is, what are you going to do? Do a stereotactic biopsy on a meningioma? That kind of seems silly, right? You're gonna just do the surgery, but we need to get access to the tissue in order to get them to figure out what the mutation status is. And so you have this horse and cart problem, like, how do you decide how to get access to the tissue? How do you decide to do the surgery? That sort of thing. And so radiomics, I think, could help us with that. Okay, and so now I just want to talk about craniopharyngioma. So the reason to talk about this disease is because this is something that is, I think, now going to be the classic example of how we should try to prioritize and manage patients, and how we should change the management of patients going forward. So craniopharyngiomas, as you all know, are rare tumors, but they're very difficult to treat. And so these are suprasellar tumors. They occur in patients, either there's a biphasic kind of presentation. They're either children or adults who have these tumors. And these, although they are considered benign tumors, are neurosurgical, very difficult to treat tumors from a neurosurgical perspective. So these are patients who develop vision loss because they compress the optic apparatus. They develop hypopituitary problems because of the hypothalamic pituitary axis compression. And then they develop all these behavioral problems as a result of the compression on the hypothalamus as well. Obviously, historically, there's been no effective medical treatment, and the major management of these patients has been skilled, surgical resection, although that's incredibly difficult to do in some of these cases, especially the ones that are suprasellar, so behind the pituitary area. And then also they've done these are patients who have been managed with radiation, and then that leads to all kinds of long-term toxicity because of how close to all of these critical neurologic structures they are, and so they have to shape the radiation fields for treatment. Historically, there are two subtypes of meningioma. There's the adenantinomatous subtype, and this is found mainly in children, although some adults as well too. And then the papillary subtype, and this is primarily found in adults. The adenantinomatous subtype had been previously reported to have alterations in what's called the beta-catenin pathway. This is a cell surface signaling pathway. And in papillary tumors, there were no previous reported drivers. In 2014 of this, and just in the last 10 years, the papillary craniopharyngiomas, Priscilla Bastianos, my colleague, and then the large group, including Sandro Santagata and a number of the investigators over at the Brigham, sequenced a bunch of papillary craniopharyngiomas, and they found out that those tumors have very low mutation rates, so consistent with the benign tumor category that we think about when we think about precision medicine. But virtually all of the papillary craniopharyngiomas, 37 out of 39 tumors that they sequenced, had the BRAF V600E mutation. So this is the mutation that is well known for melanoma and thyroid cancers and all of these subtypes. Now, this is a key thing from a diagnostic standpoint. So basically, we now, sometimes when we do stereotactic biopsies on these tumors, we often don't provide the pathologist with enough tissue to get that nice architectural distinction between adenantinomatous and papillary. And so now we have a molecular test where we can definitely distinguish between adenantinomatous tumors that have the beta-catenin alterations and the papillary tumors that have the V600E alterations. But more importantly, the V600E mutation has very well characterized systemic treatment agents that work really well in melanoma. And now we're proposing a scenario where if you have a patient who has a papillary craniopharyngioma, maybe what we should do is try to treat them with dabrafenib, trametinib, or any of these BRAF/MEK inhibitor combinations. And so in a case report that we reported in, I think this was 2015, we reported this case. This is a patient, Will Curry's, who actually came in while I was on call with a multiply recurrent cystic papillary craniopharyngioma and vision loss. And so he was presented with a large regrowth of tumor after a surgery, I think it was his third surgical resection, and he had this tumor coming in. And so we knew that this was a papillary craniopharyngioma based on one of his prior operations. And this data had been emerging that these tumors were BRAF V600E mutant. And so what we did is, working with medical oncology Priscilla Bastianos' team, we worked with the FDA to get a single patient IND so we could treat the patient using dabrafenib and trametinib. And what we found was just an unbelievable response. So the patient in less than 2 weeks had almost 50% response of tumor mass to the treatment. And especially when we added the MEK inhibitor, we had it was 85 to 90% clinical response rate to this treatment. And you can see basically the cystic and solid components of the tumor shrunk up. This was a dramatic therapy for the patient. So this patient eventually ended up getting targeted radiation to that area. But even just that goal of shrinking the tumor and shrinking that radiation treatment field so that it could be taken away from the nearby neurologic structures was a major advance in terms of this patient's care. So we recognized that this had the possibility of being the transformative treatment for patients who have this disease. And we immediately went to the Alliance Clinical Trials Group, the National Neuro-Oncology Group, and said, can we enroll, this is a rare tumor, we're going to need to recruit from many sites. Can we open an enrollment of a large series of patients who have this? And we opened the study using BEM-CoV, so the BRAF MEK inhibitor combination for patients who have biopsy-proven papillary craniopharyngioma that have the BRAF alteration. And so this study has now fully accrued, and the results of this study will hopefully be presented at a national meeting in the upcoming year. Needless to say, we're very excited about the possibility of broadening the treatment with the BRAF MEK inhibitors to this entire patient population. There have been a number of case reports now showing that this kind of dramatic response is not a one-off phenomenon. Most patients who have been treated and with this combination really do have 80–90% response rate in terms of their tumor shrinkage. So this is an important question. So now patients come in, and maybe the new management of these patients should be that we biopsy them or somehow figure out that they have the BRAF alteration, and so we can give them the drug treatment preoperatively, so in the neoadjuvant setting, either before surgical resection or before they get radiation. And so we worked with Shingo Fuhio, who is a postdoctoral fellow, a neurosurgeon from Japan, who came and worked with us for a few years. And we looked to develop a clinical rule. So what are the types of features that would identify patients who have BRAF alterations in their craniopharyngiomas? And really, it's a series of three very simple criteria that are easily generalizable across many centers. So if you're an adult, so age greater than 18, if you have a supradiaphragmatic location of the tumor, and the tumor does not have calcifications on CT scan. These are the kappa statistic on inter-observer agreement of these types of variables is very high, and so that's good because you don't get into fights with your colleagues over whether or not they meet the criteria. And then also, this is a way to enrich for BRAF mutations. So greater than 50% of patients who have these three criteria have BRAF alterations, and these could be the type of rule where we would do test doses like they used to do for germanomas, or we think of this as like a prolactinoma now. This would be something where we would give a patient a BRAF MEK inhibitor ahead of time. Trying to shrink these midline tumors to get them into the range where we can either avoid surgery or make the surgery much safer for the patient or make the radiation treatment much safer for the patient. So in summary, to us, this is like the signature example of precision medicine for brain tumors. Papillary craniopharyngiomas, they're defined by mutations in the BRAF V600E protein, and these tumors have remarkable sensitivity to the BRAF MEK inhibitors. And we're hoping that the clinical trial will sort of secure that as a new treatment for patients who have these tumors. So in general, I would like to leave the audience here with this general lesson that these types of tumors, when we think about brain tumors and precision medicine for brain tumors, we're really looking more for the benign type of tumors from a genomic standpoint. Now, the tumors can have a very morbid clinical course like craniopharyngioma, but they have a benign underpinning. They're tumors that have simple genomics. These are probably the tumors that are the best candidates for further study to try to prioritize for targeted therapies. And as we go forward, we're thinking about things like meningioma, things like craniopharyngiomas, these difficult to treat tumors that could be, as we treat these patients surgically, we could be aided by understanding the molecular genetics and by treating them with systemic therapies. So I want to acknowledge the group at MGH. This is Hiro Wakamoto and my lab group, the Translational Neuro-Oncology Lab. We've done a lot of this work. Here's Tarek Duratli, who led a lot of the work with meningiomas. And then, of course, I want to acknowledge Fred Barker, Will Curry, and all of the collaborators that we have at MGH and across all of the different sites here in Boston. And then thanks to the patients and families, of course, for participating in the research efforts here. So I want to just pause there and take any questions. Thank you very much for the ability to present here today.
Dan, that was excellent. Eric, do you want to lead off, or Raphael? Please feel free.
Yeah, no, thank you so much for that talk. It was really, inspiring to hear that progression. One thing I wanted to ask is that you had mentioned the possibility of shrinking, meningiomas with some medication beforehand. Have you have you actually started any of that, or how's that response been looking like? You know, some of those tumors are obviously really, really big, very thick, you know,
Right.
and
Yeah, I think that's a good, so that is, I think that's the key hard question for the future is how do we operationalize that on a day-to-day basis? You know, we all know what it's like to care for patients. They come in and we receive them, you know, at a certain point in their natural history, and we don't have information about what their tumor genetics is yet. And so I think to some degree, that's going to be the job of the neurosurgical oncology, you know, cancer neurosurgeon in the future is going to be how do we safely navigate that first week where we know about the patient and they maybe need urgent treatment because of, you know, vision compromise or something like that. And how do we figure out what subtype their tumor is, get them prioritized for a treatment. Maybe we have to do a subtotal resection initially, you know, sort of a safe subtotal. It's hard to figure out how we're going to do this. But I think what we look to is these examples like prolactinomas, right? Those patients sometimes will present with, you know, vision compromise because they have a huge tumor. And then they have this blood test where they can identify that the patient has a prolactinoma, and then they very carefully will try to treat them through that first week or two. And then if they see things going in the right direction, then they say, okay, we can hold off and let's just try to get as much mileage as we can out of this medical treatment. And so that may be what we're going to have to do as these patients come in who have meningioma, who have midline tumors that we think are craniopharyngiomas, either be doing these small, minimally invasive biopsy type procedures or subtotal resections where we're decompressing the optic apparatus. And then we're hoping, you know, fingers crossed that they have the mutations that we can then target. But then also we need to build up this evidence base that shows what the response rate is to these drugs. Is there going to be a reasonable response rate, or is that just a pipe dream for some of these subcategories? We're hoping that we see response rates like we see in the papillary craniopharyngioma case. Those response rates are really dramatic, but some of these meningiomas may not have that. And so we have to try to figure out what that's going to be like. Response rates for the AKT inhibitors, there have been case reports for those, but the smooth end is less clear. So we're going to have to see how that goes.
Mm-hmm. Wow, thank you.
Mm-hmm.
Ben, I have a question about the comment, the point that you made about immunotherapy. And you made the point that immunotherapy doesn't work for a high-grade tumor with a lot of heterogeneity, but it may work for low-grade tumor. I always think that low-grade tumors, because they don't have a lot of mutations, they don't have a lot of tumor antigens, they are essentially flying under the radar.
Yes, exactly.
Can you elaborate on that? Why do you think immunotherapy would work on lower grade tumors?
Right, that's a key question. So yes, the best predictor of immunotherapy working right now is having a tumor that has a complex mutational pattern. So melanoma is the, you know, classic example. There's thousands and thousands and thousands of mutations in melanoma because of it's driven by UV exposure. And the earliest tumor cells there carry tons of passenger alterations that make it a great target for immune recognition. The idea behind giving immunotherapy to these more advanced, quote unquote, benign tumors, and, you know, I'm using the word benign loosely there, is I think the example would be the BAPT1 alteration. So in rhabdoid meningiomas, BAPT1 is a predictor, you know, is an alteration that is seen. And we just recently reported last year that in papillary meningiomas, which is a subtype, a grade 3, WHO grade 3 classical subtype, they have PBRM1 alterations. PBRM1 is a mutation that it changes the expression of many, many different genes. And in renal cancers, it's actually a predictor of response to immunotherapy. And the idea is that somehow by hitting these sort of global gene expression alterations, that you make so many changes that you start to have a tumor that, even though it has benign mutational genomics, it has very heterogeneous expression genomics, and then that makes it good for immunotherapy. And so one idea behind immunotherapy for meningioma would be to try to identify these papillary or rhabdoid tumors, you know, knowing that they have BAP1 alterations or PBRM1 alterations, and then those would be the candidates. Now, those are very rare tumors. Any one center like MGH or BI is going to see maybe one patient a year. And so a study like that is really going to need to be like a nationally run study, because we're going to have to, ask for tissues from many different places, categorize them for whether or not they have the BRAF alteration or the PBRM1 alteration, and then bring those patients in a kind of an organized way through treatment with immunotherapy. We're going to have to know if that immunotherapy either leads to a response rate or otherwise changes the natural history of that subclass of disease. And ultimately what we're doing there is we're like redefining what meningioma is. We're saying that, oh, this is a separate slice of meningioma that we treat differently compared to the other groups of meningioma. So that's, I think, going to be the pathway for that. I think giving immunotherapy to classical grade 1 NF2 mutant meningiomas is probably not a good idea for the reasons that you recommend, that you alluded to. These are not complicated tumors. These are tumors where I think we should be looking for targeted therapy types. So tumors like, things like AKT alterations or FAK inhibitors, things like that. So.
I got one other question for you, and that is, have you taken into account, some of the delivery of this targeted therapy and how blood-brain barrier takes to, effect?
Yeah, I mean, that's a key thing. So we see that play out mostly in the metastasis world, right? I mean, you guys are probably very familiar with this, right? The transition from erlotinib to osimertinib in lung cancer is driven primarily by the fact that osimertinib has better blood-brain barrier penetrance, and it's very good for treating patients who have brain metastasis from EGFR mutant lung cancer. And I think that that is also a factor in melanoma as they've moved from vemurafenib to dabrafenib to then now oncovini. It's that potency question and that question of getting across the blood-brain barrier gives us more hope that these would be useful for patients who have tumors that are behind the blood-brain barrier. I think the way we're really going to see that is in these kind of like indolent low-grade what are called glioneuronal tumors. So these are these tumors that grow in patients in their brainstem or in the hypothalamus, these kinds of things where, obviously we're not going to be able to surgically manage the patient, but a targeted therapy for that has good blood-brain barrier penetrance could maybe manage those patients well. And so I think that that's going to be something where we're looking going forward. The blood-brain barrier, I think for something like meningioma, maybe doesn't matter so much, right? Because that's more on the surface. It's clearly pretty well vascularized in a lot of cases. It obviously didn't matter for papillary craniopharyngioma. That's sort of outside of the brain or near the brain. But then these tumors that are intrinsic to the brain and are non-enhancing, I think it's going to be a big deal to have a drug with good blood-brain barrier penetrance.
Well, Dan, thank you again. And I think you're close enough in town that if other people have questions, they're happy to find you, email you in the MGH Brigham system, and and vice versa. But it was a delight getting this run through. A really great work, and I thank you for taking the time to do it.
Thanks very much for having me. And obviously we look forward to ongoing collaborative work as we, this is a field that is so rapidly changing that every time somebody sees an odd case, a lot of times we can learn something from it. So I'm hopeful to keep the lines open. Yep.
Certainly strength in numbers for these. We find that in vascular work too, that instead of 5, you end up with 35 if you collaborate with 3 or 4 or 5 institutions. So we invite it and encourage it. And thanks very much for your time.
Excellent. Thanks so much.
Take care.